Have you ever stopped to think about the sort of unsung heroes inside your own body? Those amazing tissues, often totally invisible, that let you bend, stretch, move, and absorb some surprising forces every single day. We're talking about the silent architects keeping joints smooth, giving shape to your nose, your ears. It's pretty remarkable, isn't it, how much complex engineering is packed into something so fundamental. Today, we're taking a deep dive into cartilage. It's this foundational connective tissue shaping us right from the womb and keeping us moving throughout life. And our guide for this journey is Histology, a text and atlas, 8th edition. It's a really fantastic resource for understanding the microscopic world within us.
Exactly. And our mission today is really to unpack the core insights from that text. We want to look at the microscopic anatomy, which is fascinating, the cells involved, the different types of cartilage, and crucially, how this all connects to real-world clinical situations. The goal is to help you grasp this complex topic pretty quickly, seeing how those tiny details impact health and movement.
Yeah, so it's not just about bones. This is about that pliable, resilient tissue working hard behind the scenes. And sometimes it's surprisingly vulnerable too. Okay, let's get into it. So just to start us off, for someone maybe not familiar, how would you describe cartilage at its most basic?
Okay, so think of cartilage as a very specialized form of connective tissue. Fundamentally, it's made of cells called chondrocytes.
Chondrocytes.
And a very specialized extracellular matrix. That's the material the chondrocytes produce and live in. And actually, this matrix makes up over 95% of the cartilage's volume. It's really the dominant component. And here's something really interesting. Cartilage is avascular.
Avascular, meaning no blood vessels.
Exactly, no blood vessels at all, which is quite unusual for tissues. So unlike most tissues getting nutrients directly from the blood, these chondrocytes depend entirely on diffusion. Substances have to slowly seep through that thick extracellular matrix from surrounding tissues or joint fluid to keep the cells alive.
Wow. So that matrix isn't just structure, it's also the lifeline. What makes it so special? How can it manage diffusion and provide support?
Precisely. It's not just filler, it's solid, it's firm, but it's also pliable. That gives cartilage its resilience, its ability to kind of spring back after being squashed.
Right.
The secret lies in its molecular makeup. It has a very high ratio of these molecules called glycosaminoglycans, GAGs for short, compared to its type 2 collagen fibers.
Okay.
Think of GAGs as tiny biological sponges. They're highly charged and attract and hold on to enormous amounts of water. This trapped water is key. It gives cartilage that hydrated, cushiony feel and allows it to bear significant weight, especially in our joints.
And it's not just about adult movement, is it? I mean, this stuff is crucial way earlier.
Absolutely. Cartilage is fundamental in fetal development. Most of our skeleton actually starts out as a cartilage model.
Like a blueprint.
Exactly, a blueprint that gets gradually replaced by bone. That process is called endochondral ossification. So cartilage literally sets the stage for our entire bony structure before we're even born.
Okay, so it's foundational. But you mentioned different types. It's not all the same stuff.
Right. We generally talk about 3 distinct types, and they're differentiated mainly by the characteristics of their matrix. Each is sort of fine-tuned for a specific job. First, there's hyaline cartilage. This is the most common type. It looks kind of glassy, homogeneous under the microscope. Its matrix is rich in that type 2 collagen, the water-loving GAGs, proteoglycans, and some specialized adhesive proteins.
Okay, glassy hyaline. Got it.
Second is elastic cartilage. The name gives it away, right? It's distinguished by having lots of elastic fibers and elastic sheets woven into the matrix, along with the standard hyaline components. This gives it real flexibility.
Makes sense.
And third, we have fibrocartilage. This one's interesting. It's kind of a hybrid. Its matrix has loads of type I collagen fibers. That's the really tough stuff you find in tendons, in addition to the type 2 collagen and other bits found in hyaline cartilage.
So it's like a blend of toughness and resilience.
Exactly, a combination tissue.
And their locations really tell the story, don't they? Like hyaline cartilage in the trachea that needs to be rigid but still flexible to keep the airway open. Then elastic cartilage in your ear. You can bend your ear completely, and it just springs right back. That's the elastic fibers doing their thing.
Right, perfect example.
Yeah, and fibrocartilage, that tough blend. You find that in intervertebral discs acting as shock absorbers between the vertebrae. Makes total sense.
It's truly remarkable, isn't it, how these relatively subtle tweaks in matrix composition, more elastic fibers here, type I collagen there, lead to such vastly different properties and functions in the body. It's really elegant engineering.
Let's zoom in on hyaline cartilage for a bit, the glassy one.
Yeah.
You mentioned chondrocytes living inside it. Where exactly are they?
Yeah, if you look closely under a microscope, you see these little spaces, almost like tiny caves or nests within the matrix. Those are called lacunae, and that's where the chondrocytes reside.
Ah, lacunae.
Yeah.
Okay. And the matrix itself, you said it's complex?
It really is intricate. The main structural component is type 2 collagen fibrils. They form this dense, three-dimensional meshwork, kind of like rebar in concrete, providing tensile strength. But there are other minor yet important cartilage-specific collagens too, types 6-9X-X11. They help regulate the size of the fibrils, organize the meshwork, and anchor cells to the matrix. Little fine-tuners.
Okay, so mostly type 2, but others help out. What about those gags again?
Right, the proteoglycans. These are huge molecules built around those gags we talked about, like chondroitin sulfate and keratin sulfate. The most important proteoglycan monomer in hyaline cartilage is called aggrecan. These aggrecan molecules are massive and have a very strong negative charge. This charge attracts and traps huge amounts of water. We're talking 60 to 80% of the cartilage's weight can be water.
60 to 80%, wow.
Yeah, it's this trapped water, bound by the aggrecan, that gives hyaline cartilage its incredible resilience to compression and its weight-bearing ability. It's essentially a super-hydrated cushion.
So water is key. And what were those other glycoproteins?
The multi-adhesive glycoproteins. Think of these as molecular glue or connectors. They help link the chondrocytes to the matrix components, influencing cell shape and function. Clinically, they can be useful too. Levels of certain glycoproteins in joint fluid can act as markers for cartilage breakdown or turnover.
Interesting. And the chondrocytes themselves, the cells living in the lacunae when they make all this matrix stuff.
They do. They're the specialized cells responsible for producing and maintaining this complex matrix throughout life. You often find them singly, but also in small clusters called isogenous groups.
Isogenous groups.
Yeah, that just means a little group of 2 or more cells sitting close together in the same lacuna. It indicates that the original chondrocyte recently divided.
Okay. And you mentioned the matrix isn't uniform. It has neighborhoods.
That's a good way to put it. Based on staining properties which reflect molecular composition, we see distinct regions. Right around each chondrocyte or isogenous group is the capsular or paracellular matrix. It's very rich in proteoglycans and specific collagens, like type 6 size.
Like a little protective halo.
Sort of, yeah. Then surrounding that is the territorial matrix, which encompasses the isogenous group. It has a different collagen arrangement. And finally, the bulk of the matrix filling the space between these territorial regions is called the interterritorial matrix. This regional variation likely reflects different mechanical stresses and functions within the tissue.
Fascinating. And going back to development, we said hyaline cartilage forms the fetal skeleton model.
Yes, most bones form via that endochondral ossification process, replacing a hyaline cartilage template. But even after development, hyaline cartilage persists in critical places. It forms the smooth articular surfaces of our movable joints, that's articular cartilage, and it also forms the epiphyseal growth plates in growing bones, allowing them to lengthen.
Right, the growth plates. Now, you also mentioned something called the perichondrium.
Yes, most hyaline cartilage, like in the trachea or ribs, is surrounded by a layer of dense connective tissue called the perichondrium. This is really important because it contains progenitor cells that can differentiate into new chondroblasts.
So it's a source of new cartilage cells for growth and maybe repair.
Exactly, particularly for appositional growth.
Yeah.
But here's a really crucial exception. Articular cartilage, the cartilage covering the ends of bones in movable joints, does not have a perichondrium.
No perichondrium on articular cartilage.
Okay.
That seems significant. Why is that important?
It's hugely important, especially clinically. It means articular cartilage lacks that source of new cells found in other hyaline cartilage types. This directly contributes to its very poor ability to heal after injury.
Ah, okay. That makes sense. And this articular cartilage, it's dealing with constant friction and load in our joints. It is structured differently.
Yes, it's highly specialized. It's organized into 4 distinct zones, running from the joint surface down to the underlying bone. There's the superficial zone, the intermediate or transitional zone, the deep zone, and finally the calcified zone, which anchors it to the bone. Each zone has a unique arrangement of chondrocytes and collagen fibrils, optimized to handle different forces: shear at the surface, compression deeper down.
So it's layered for performance.
Precisely. But that complexity, combined with the lack of perichondrium and its avascular nature, makes it vulnerable. Mature articular cartilage renews itself incredibly slowly.
Which brings us, unfortunately, to the clinical side. What happens when this system starts to break down? I guess we're talking about osteoarthritis.
Yes, exactly. Osteoarthritis, or OA, is a very common degenerative joint disease, strongly linked to aging, mechanical stress, injury, and genetics. Essentially, what happens is a decrease in those vital proteoglycans within the matrix.
The water-binding sponges.
Right. So the cartilage loses water content, becomes less resilient, less cushiony, and more susceptible to damage. Inflammatory factors also play a role, stimulating enzymes called metalloproteinases.
And they do what?
They basically degrade the cartilage matrix, chew it up.
Yeah.
It starts with fibrillation, like little cracks on the surface, and can progress until the cartilage wears away completely, exposing the underlying bone.
Ouch. Bone on bone.
Yeah. And that leads to the classic symptoms: chronic joint pain, stiffness, reduced mobility, sometimes joint deformity. It's a major cause of disability worldwide.
And currently there's no cure, right? Just managing symptoms.
Unfortunately, that's largely correct. We can manage pain and inflammation, recommend exercise and weight loss, and eventually consider joint replacement surgery, but we can't yet reverse the underlying cartilage degeneration.
Man. Okay, another process you mentioned affecting hyaline cartilage is calcification. Is that always bad?
Not necessarily. Calcification, where calcium phosphate crystals deposit in the matrix, is actually a normal part of three processes. One, it happens naturally as we age, typically in deeper layers of articular cartilage or in costal cartilage. Two, it's absolutely essential for endochondral ossification bone-replacing cartilage. And three, the deepest zone of healthy articular cartilage is the calcified zone, anchoring it to bone.
Okay, but can it become problematic?
Yes. When calcification becomes too extensive, especially in areas not normally calcified, it blocks that crucial diffusion of nutrients through the matrix.
Cutting off the chondrocyte's lifeline.
Exactly. The chondrocytes can die because they can't get nutrients or get rid of waste. The calcified matrix might then be resorbed, often by cells called chondroclasts, which are similar to osteoclasts that break down bone, and the area might eventually be replaced by bone tissue. You sometimes see this on older adults' tracheal rings.
Okay, and so hyaline cartilage has its challenges. What about elastic cartilage? Its big thing is flexibility, right?
That's its defining feature. The matrix is packed with elastic fibers, giving it that ability to bend significantly and then snap back to its original shape. Think external ear, epiglottis, places that need that springiness. Importantly, unlike hyaline cartilage, elastic cartilage does not calcify with age. It stays flexible throughout life, which is obviously critical for its function.
Good design. Okay, and the third type, fibrocartilage. The hybrid one.
Right. Fibrocartilage is that unique mix of dense, regular connective tissue and hyaline cartilage. Its matrix has lots of tough type I collagen and the type 2 collagen typical of hyaline cartilage.
So it gets strength from both.
Yes. It's designed to resist both compression and shearing forces. It's incredibly tough and acts as a fantastic shock absorber. You find it in intervertebral discs, the pubic symphysis, and knee menisci, all areas under tremendous stress.
And does it have a perichondrium?
No. Fibrocartilage typically lacks a perichondrium, similar to articular cartilage. And clinically, degeneration of intervertebral discs, a common cause of back pain, often involves the breakdown of its proteoglycans, weakening that shock-absorbing capacity.
So we have these specialized tissues. How did they actually form in the first place? What's the origin story?
It all starts during embryonic development in a process called chondrogenesis. It begins with mesenchymal stem cells.
Okay.
These are sort of precursor cells. A specific group called chondroprogenitor cells cluster together. Then a key signal, a transcription factor called SOX9, gets turned on. SOX9 basically tells these cells, okay, you're going to become cartilage cells. They differentiate into chondroblasts. The builders, exactly. They start actively secreting the cartilage matrix components around themselves. As they get fully encased in the matrix they've produced, they mature into chondrocytes, the cells we find in the lacunae.
And once formed, how does a piece of cartilage actually get bigger? How does it grow?
There are two main ways cartilage grows. The first is appositional growth. This happens at the surface. Cells in the inner layer of the perichondrium differentiate into chondroblasts and start laying down new matrix on the outside of the existing cartilage. It's like adding new layers to an onion.
Growing from the outside in? Sort of.
Or rather, adding to the outside surface. The second method is interstitial growth. This happens from within the cartilage mass itself. Existing chondrocytes inside their lacunae can still divide, especially in younger cartilage. These daughter cells then produce new matrix, pushing themselves apart and expanding the cartilage from the inside.
Ah, okay. Appositional on the surface, interstitial from within. So it can grow.
Hmm.
But the big question, especially thinking about joints, can it heal?
Ah, that's the million-dollar question, isn't it? Unfortunately, the answer for hyaline cartilage, particularly mature articular cartilage, is not really. Its capacity for repair is extremely limited.
Why is that? It seems counterintuitive for something under so much stress.
It comes down to those key features we discussed. One, it's avascular. No blood supply means no easy way to bring in repair cells, growth factors, or nutrients needed for healing. Two, the chondrocytes are trapped within that dense matrix in their lacunae. They can't migrate to the site of injury like cells in other tissues can. And three, mature chondrocytes have a very limited ability to divide and proliferate to replace damaged tissue. It's just a tough environment for repair.
So even a small tear or damage,
Yeah.
it just stays there or gets worse.
Often, yes. Minor damage might persist indefinitely. If there is some attempt at repair, especially if the injury reaches the underlying bone or involves the perichondrium where present, it usually doesn't result in new, healthy hyaline cartilage.
What happens instead?
You typically get the formation of dense connective tissue, basically scar tissue, or sometimes you get fibrocartilage forming instead. While that might fill the defect, it doesn't have the same smooth, resilient properties as the original hyaline cartilage. Functionally, it's never quite as good.
So scar tissue instead of the real deal.
Yeah.
That explains a lot about chronic joint problems after injuries.
Absolutely. It's a major challenge in orthopedics and sports medicine. It also has implications in other areas like cardiothoracic surgery when they have to cut through costal rib cartilage. It doesn't heal reliably.
Are there any new approaches trying to tackle this poor healing?
Yes, researchers are working hard on this. There are techniques involving microfracture to stimulate bleeding and hopefully some repair, using perichondrial grafts, transplanting healthy cartilage cells, or using tissue engineering scaffolds seeded with cells or growth factors. But we're still searching for a truly effective, reliable way to regenerate high-quality hyaline cartilage.
A huge area of research, I imagine. Okay, let's touch on one more clinical correlation. Chondrosarcomas. What are these?
Chondrosarcomas are malignant tumors that arise from cartilage cells. They're relatively rare compared to other cancers, but they are the second most common primary bone cancer that actually produces matrix.
Okay, malignant cartilage tumors. Where do they typically occur?
They tend to occur more often in adults, usually over 45, and slightly more in men. Common locations include the bones of the pelvis, ribs, shoulder girdle, the axial skeleton, but also the ends, the metaphyses of long bones like the femur and humerus.
And what are the symptoms? Is it obvious?
Often not initially. Because cartilage doesn't have nerves, the tumor itself might not be painful early on. Symptoms often arise later, like a dull, deep ache or pain as the tumor grows and puts pressure on surrounding bone or tissues, or sometimes a noticeable lump. Diagnosis relies heavily on imaging, X-rays, CT scans, MRI, to see the lesion within the bone.
And are they all the same or do they vary in severity?
They vary significantly. They're graded histologically, meaning by looking at the cells under a microscope from grade 1 to grade 3. Grade 1 tumors are low-grade, slow-growing, and less likely to spread. Grade 3 tumors are high-grade, much more aggressive, and have a higher risk of metastasis. The grade is a key factor in prognosis.
Can we tell anything else from the tissue itself?
Yes, sometimes immunohistochemistry using antibodies to detect specific proteins in the tumor cells can provide prognostic clues. For instance, the presence of typical cartilage components like type 2 or type X collagen and aggrecan might suggest a better prognosis. Finding type I collagen, which isn't typical for hyaline cartilage, might indicate a poorer outlook.
And how are they treated?
The main treatment for chondrosarcoma is surgery, wide surgical excision to remove the entire tumor with a margin of healthy tissue. Unfortunately, these tumors are often resistant to traditional chemotherapy and radiation therapy, so those usually play a limited role, primarily reserved for high-grade or inoperable cases.
Wow. Okay, so we've covered a lot of ground there. From the basic structure, the glassy hyaline, flexible elastic, tough fibrocartilage.
Right, through to how it grows, why it struggles so much to heal, and some of the serious clinical issues like osteoarthritis and chondrosarcoma.
You've really given us a deep dive into this fascinating, complex world of cartilage. From that glassy look and amazing water binding ability to its growth and, yeah, its frustratingly limited repair.
We've definitely seen how this tissue, which might seem simple on the surface, is actually a marvel of microscopic engineering. It's absolutely essential from fetal development right through to supporting our joints every day. But it's also uniquely vulnerable, isn't it? To age, to injury. Understanding its structure, its cells, its types really highlights its importance and those clinical challenges.
It really does. And it leaves you thinking, given these limitations, especially in healing, what kind of breakthroughs are on the horizon? What might truly revolutionize how we treat joint injuries, how we tackle diseases like osteoarthritis that affect so many people? Could we one day make cartilage repair less of a struggle? Something to ponder. Well, thank you for joining us on the deep dive today. We really hope this exploration of cartilage has given you a new appreciation for the incredible, often hidden architecture working away inside your own body.